and for having me here today to speak to you guys about palliative medicine, which is an area of medicine that is ongoing and growing. And we're having to educate a lot of our, not only our patients, but our colleagues as well as to the importance and the benefits of having palliative medicine follow patients along. So this is just an introduction to palliative medicine. So why palliative care? Thanks to modern medicine, as you can see from all the lectures that you guys have been participating in these past couple of days, people with serious and complex illnesses are living longer. The problem that we're seeing is that a lot of the healthcare today is fragmented, and it's difficult to effectively treat and continue to treat people that are living with serious illnesses. Palliative care is interdisciplinary, team-driven, and focused on patient-centered outcomes such as quality of life, symptom burden, emotional well-being, and caregiver needs. So the previous discussions about symptoms and all those, these are a lot of the things that we deal with on a daily basis and the importance of this for patients in their care. It emphasizes on communication and continuity of care, fits the episodic and long-term nature of serious and multifaceted illnesses. So not only it can be while patients are suffering for that acute illness, but it also serves for people that have ongoing needs as their disease progresses or maintains. So what is palliative medicine? Palliative medicine or palliative care is a specialized area of medicine for people with serious illness regardless of their diagnosis. It focuses on providing patients with relief from symptoms, pain, stress of serious illnesses. Its goal is to improve the quality of life for both the patient and the patient's family. It is appropriate at any age and at any stage in the disease process. This is one of the big things that we're trying to re-educate people on, is that you continue to benefit, or you may receive the benefit of palliative medicine throughout your disease process, as early as the diagnosis to as late as the end of life discussions. What is palliative medicine? Continue. Working in partnership with your primary physician or your primary oncologist, the team provides time to devote to intense family meetings and patient and family counseling. So the way that I explain palliative medicine, and one of the biggest benefits in palliative medicine is I give my patients the time with their oncology to discuss their cancer and cancer treatment. You have a limited time, or you have some time to speak to your oncologist. I want my patients to spend that time speaking about the treatments and their issues of ongoing cancer. So all of the other symptoms and things that are occurring with you, related or not, with the cancer, let me take that. Let me help you with that. Let me clear the table for you so that your oncologist can focus on what they're so well trained to do. Skilled in communication. Even though I'm fumbling on my words and I'm not very good right now, I am skilled in communication and speaking about serious illnesses. I hold a lot of family meetings, not only with patients and with their families, to discuss their care. This is the largest family meeting that I've had in a very long time. So be patient with me and bear with me when we'll get through this, okay? Expert in management of complex physical and emotional symptoms, such as complex pain, depression, anxiety, fatigue, shortness of breath, constipation, all of these different symptoms, all of these things that can... Sorry. Is the microphone?
I give you another mic.
Okay. Maybe I'm not holding it.
You're good. It's just that. No, that one's just quiet. This one's louder. That's really quiet.
Okay, my communication just got way better. Now I sound like an expert in communication. There. Okay. So expert in management of symptoms. So all of these symptoms that are related to your disease process, we try to help you with those. If you're dealing with pain, and pain is probably one of the things that we deal with the most and having to help people with the most, trying to help people along with those things. The one thing that I would add to the comment about the symptoms and how it relates to the recurrence of your tumors and how you should monitor that, if I could add something to that discussion, it would be, how does your symptom impact your functionality? How is your symptom affecting your quality of life? And how is your symptom affecting your ability to function on your day-to-day? If there is a significant decrease in the ability to function on a daily basis, that's when you have to pay an added attention to that symptom. Okay, so pain is a good example. The pain will Pain throughout your disease process will get better, get worse, and change and fluctuate. But if it continues to decrease and it continues to impact your day-to-day living and it continues to impact your quality of life, that's something that you have to address. And that's something you have to speak to your palliative care physician, to your oncologist, to whoever is managing your care. Coordination and communication of care plans amongst all providers and across all settings. So it goes back to the discussion of the fragmentation of the healthcare system. Sometimes you have a multidisciplinary team that's taking care of you, and you have all of these different specialists, the radiation oncologist, the oncologist, and sometimes you have a primary oncologist and a sarcoma specialist, and your primary care physician that's addressing all of your other medical conditions. And some of those lines of communication are broken. You need to have somebody that is actively trying to get those people to talk to each other and coordinate care. So who may benefit from palliative medicine? This is it's hard for me to say without me being biased because I'm a palliative care physician, because I believe that almost every patient would benefit from palliative medicine. But these are some of the recommendations that our society have put forth in patients that will definitely benefit from palliative medicine. So if you have the presence of any of these, metastatic or locally advanced cancer progressing despite systemic treatment, Karnofsky score or an ECOG score, these are functional scores that your physicians are doing to check, to monitor how your cancer is being affecting your quality and your functionality of life. Brain metastases, spinal cord compression or neoplastic meningitis, malignant hypercalcemia or hypercalcemia in general, and progression of pleural and peritoneal and pericardial effusion. So those are definite things that occur, that may occur with patients that will have a significant burden in functionality, and therefore it is important that a palliative care physician be involved in your care. So we talk about domains and the domains of palliative medicine. So control of pain and symptoms and the side effects. So not only the side effects of your disease, but the side effect of the treatment that is being geared towards your disease. And every different type of treatment is going to have a specific disease or symptom process or side effect process. So it's important that you have somebody that's addressing those needs. Okay. I had a professor tell me once that every single medication has a side effect. Holy water at a specific concentration will cause side effects as well. So anything and everything on this earth, if it's given enough, will cause side effects. Caregiver burden. We tend to forget how important it is. And when I take care of patients, I remember that I'm taking care of that family and the burden that is, and the burden that is added on to the people that are supporting that person that's going through the disease. So it's important when I go to see my patients in the hospital, I'm met by the family at the door before I go in to see my patients. So the first thing I do is I get a report from that family member of what happened the day before. And I never leave that conversation, and we'll talk about it for a while, and then I never leave that conversation before asking, how are you doing? How are you doing with all of this that you're dealing with your spouse, your son, your daughter, your family member? How are you coping with all these things? This is just as important, we tend to forget. Because we're so, and rightfully so, everybody is so focused on the person and the patient and what that person is going through, we tend to forget all the people that are around it and providing a good amount of support. Social support and spiritual support as well. So there is an elephant in the room, a big white elephant in the room, and I have to address it, and it is the difference between palliative medicine and hospice. There is a lot of misconceptions as palliative medicine are hospice physicians, or hospice physicians camouflage as palliative medicine doctors, but it's not the case. So every person that receives hospice care will receive palliative medicine or palliative care. But you can receive palliative care without receiving hospice care. Hospice is a model of palliative care restricted to people that are end of life. Palliative care is appropriate for any age and again at any stage of your illness. It doesn't show very well, but you can see here that the hospice ball is inside the palliative care ball. This is probably one of the best pictures that I have to present today, and if I could, I'd put this on my license plate, as I like it so much, because it gives us a good idea of what palliative medicine is. The only thing that I don't like about this is it always ends up with this discussion of death, and that's not always the case. But you can see the progression of the disease is going to be a fluctuation of symptoms and how it progresses. So as you get, and the pointer is the
Movement, yeah.
there we go. As you can see, you'll have episodes of improvement and worsening of your symptoms, and that's when palliative care should help. So while you're receiving curative and restorative treatment, you can receive palliative medicine treatment as well. It's only after a certain time that it's been decided that your disease has progressed to end of life that you can receive benefit from hospice meds. It's probably too big for a license plate anyway. Okay, so I had this article that actually was done in lung cancer patients, but it did show a significant improvement in patients receiving care of palliative medicine physicians while they're receiving their treatment. So it was published in the New England Journal of Medicine in 2010, 151 patients with lung cancer, all of them receiving similar oncological care. Some of them did receive palliative, they had a palliative care group that showed better quality of life, lower levels of depression associated to their disease process and in general, and actually showed a longer survival rate by 2.7 months, which is for lung cancer patients a significant amount. This one's way too big for us to talk about, but here is the treatment, and this is another article that was published, and it looks specifically as to patients that were receiving palliative medicine were more likely to continue with their curative treatment because all of their other symptoms were being addressed at the same time. And you can see here on the diagram, this was a control of people that weren't receiving palliative medicine. You can see a significant improvement for us. The patients continued with the care. So it's interdisciplinary, like I said. And I did see a slide from Raphael earlier in the multidisciplinary care, and it didn't include palliative medicine, which broke my heart. I'll talk to him about it. So this is how I look at interdisciplinary. The first thing that I look at is the patient and the patient's family always have to be in the center of this discussion. You and your family members are the drivers of everything. You are the ones that are making the decisions. It's our job to give you the options, and it's your right and your obligation to decide how you want to approach that care. By doing that, we give you a network of support that is able to help you along those decisions. I love my oncologist, so I put him right on top here. I wanted to keep inviting me to these lectures and keep educating people on palliative medicine, so I put him on top bill right here. Palliative medicine, medical health providers, pharmacy, integrative medicine, physical therapy, social worker, pastoral care, nursing care, all of these people working together to make sure that all of your symptoms are being addressed and your medical condition is being addressed. Is associated to severe illnesses are associated to a significant sense of loss affecting all aspects of care. So it's important that we address all these things. There is a definition of suffering is a state of severe distress associated with events that threaten the intactness of a person. And that is the biggest thing that palliative medicine wants to tackle. My goal is to eliminate or decrease suffering. I let the oncologists, the radiation oncologists, and the oncological surgeons treat cancer. My job is to treat suffering. So for patients and for patient families, comprehensive care of cellular illness patients requires skills and resources of a multidisciplinary team. This does not work. If I am a one-man band, I cannot do this. I need that group of people that's helping me along, that's providing all those different aspects of the care. The team has a shared goal to identify and manage suffering. Suffering is my goal. To treat suffering is my goal. So it integrates many perspectives, encourages teamwork to craft creative solutions to difficult problems, develops formal and informal solutions to address complex problems, develops solutions with depth and breadth, and shares responsibility for leadership, and empowers individuals on the team and empowers patients as well. The biggest thing that I hear back from patients is, you're allowing me to be a part of my medical care. By listening to what is important to me and what is relevant to me, now I'm being a part of my medical care. Okay, so I said that it's a lot of symptoms. I focus a lot of pain because pain is what we see the most. But this is something called the Edmonton Symptom Assessment System. And I tell my fellows that they have to do this on every single one of their patients that they see. So all of these different symptoms that we're looking at, pain, tiredness, drowsiness, nausea, lack of appetite, shortness of breath, constipation, so on and so forth. It's important that we reach out and speak to every single patient about all of these different symptoms, and for you to tell us what is it that is affecting you the most. What I tell patients when they see me the first time is, the first thing that we're gonna do is we're gonna build a list. Doctors tend to work on lists, or at least I do. And we're gonna go through a list of your symptoms and your medical conditions. And we're gonna number them from 1 to, I'm a geriatrician, so 10, 15, 20, right? But the order of that list is the one that you're gonna give me. We're gonna make the list together, you're gonna tell me what the list order is. So if the pain is the thing that's bothering you the most, that's gonna be the number one on your list, and that's gonna be the first thing that we're gonna take care of. Okay, so the concept of total pain is a concept of palliative medicine that looks into the holistic approach of pain as a symptom. So it's a term used to describe the physiological, social, emotional, and spiritual and physical experience of pain. Beyond its physical dimensions, pain threatens the intactness of a person. Physical pain may be directly caused by illnesses, treatments, or comorbidities. Existential or spiritual pain arises from the impact of a person's sense of control, identity, justice, and meaning. This is very important, and a very good example of this is chronic pain. So chronic pain, by definition, is pain that lasts more than 3 weeks or after the tissue has been healed. So it's easy for me to make sense of pain that's happening when I recently had a surgery and I can see the scar there and it's still open and it's still healing. It's easy for me to make sense of that pain. But when that's completely healed and I don't have a trace of that pain and a trace or a reason for that pain and I still have the pain, psychologically I can't make sense of that pain, but I still have it. So it still needs to be addressed. And that's what's important, and that's what we try to work on. These are the different types of pain, and a different classification of pain. The thing about sarcoma is all of these different types of pain, be that neuropathic pain because of nerve damage, somatic pain because of soft tissue or bone damage, visceral pain because of damage to organs, or cancer-related bone pain, which is also, all of these can be present in sarcoma patients. All of these have a different way of presenting. All of these have a different way to treat them. Things that work better or worse for those specific pains. These are different types of different ways that we have to treat pain. So we tend to go right to the top, right? I have a lot of pain, just give me my Percocet and I can go, right? And in reality, as we're seeing, there's a lot more need for other types of interventions that can help you with the pain. Be that intervention like injections and blocks and spinal analgesia, rehabilitation and physical therapy, psychological tools that we can use to help patients with pain, neurostimulation, and complementary and alternative medicines, which we're working with as well. This is a bad slide. I use this to scare oncologists. I put this slide up, and all the oncologists, I go, these are the different types of cancer pains that your patients are going to have to use. This is how I get them to call me and help them out. You look at all of these different things that are related either to the tumor or related to the treatment for the tumor that could cause pain in patients dealing with cancer. So it's important for us to have an idea of how to specifically treat all those things because all of them have a specific thing that they're going to respond to. Okay, so This is, I like to put a picture of the palliative care physicians and the nurse practitioners I work with at the University of Miami. And this is our team. And that's it. That's all I have for palliative medicine. I took that back. There's a lot more to palliative medicine.
Does anyone have any questions?
Could you differentiate the difference between what you're certified in versus a psychiatrist versus psychologist versus social worker? It seems like all of that is a team under you.
So we all work together, right? So in our team, and our team is showing up there, we have a social worker that works with us directly, and all of us play a role in the care. So once we've identified a symptom specifically, there are different areas that are impacting that symptom that we need to take care of. So if we have a mental health expert, they'll come in and help us with specific strategies or techniques that can help with those symptoms. We tend to be more specialized into the specific treatments to manage those symptoms. So we're qualified to treat pain and the different pain medications and different pain treatment modalities that can help the patients. And I think that the social workers are a big component of this. They help us navigate the non-medical but very important things that patients are dealing with. And we tend to forget that, and it's always good to have a social worker to remind us, well, this medication is great, but the insurance company is not going to cover this medication. So you need to help me with, we need to change this around. We need to find a different alternative for this. Those kinds of things. Or, it's great if you can send them home with this specific medication, but he's not going to be able to continue that at home. So you need to, or this patient does not have a home to go home to. So we need to start coordinating a rehabilitation center or things of that nature that can help us along. So it is very much so a team approach. In the interdisciplinary rounds that we have on a daily basis, we discuss all these different aspects and everybody provides an input. I don't know if that answered your question.
Not necessarily a question, but just something to share. When my sister was introduced to palliative care, she had uterine myeloma sarcoma cancer. She passed. I remember she was in the hospital and someone came in and we didn't know to share with her that she was going to have palliative care. And at the time, because neither she nor we were not familiar with it, we honestly thought it was hospice in disguise. And so it was very scary. It was very scary. However, I was happy that as my sister worked with palliative care, she was able to not only have her pain managed, but also she met with people who were able to help her with some of the pain that was in her soul. Some trauma that she had experienced as a young girl that she had not had an opportunity to talk to anyone about. And so in addition to the physical pain, while my sister was under the care of palliative care, she was able to get additional treatment and care that she had not gotten over many, many, many years. I think that also helped her to bring things full circle. So, so in the end, even though we were very suspicious at first, it ended up being something that was very good for her and very necessary. And everyone that worked with my sister in palliative care, they were absolutely wonderful and walked with her, until the very end. So I definitely have an appreciation for it now.
What I would say to that is the fear that we have, and it's a normal fear to have, is because historically we've been added to the discussion too late in the care. And that's one of the biggest things that we have as palliative medicine physicians is we would like to be involved very early on in the journey of cancer treatment. Call me crazy, but my idea is that your first visit should be with an oncologist to discuss your treatment. Your second visit should be with a palliative medicine physician, so that you have somebody in your corner that is going to help you navigate through that treatment. I hate to say journey because that word's become kind of misused, but going through the treatment of the cancer and understanding what are the things to expect, what are the side effects to expect for the treatment, how that's going to impact your day-to-day, and prepare for those things and have a plan in motion and have, talk about those things that nobody talks to you about. What is going to be your safety, your network of people that are going to help you through this, and identify those things. Unfortunately, people that are living with cancer and have lived with cancer historically had to make those decisions on the fly and not have somebody that's been through that before or been a part of that journey with somebody else guide them through those decisions.
Thanks again, that was, see, I have too loud of a voice for this one, I need to go back to that. Okay. Thanks. Okay, thank you so much for that. That was really, and that's the key, is that we don't use our palliative care team as often as we should because of the kind of the connotation that, that's associated with hospice. No, it's not. It's associated with helping, relieve your symptoms of pain or whatever side effects you've experienced. So thank you so much. I really appreciate that. The next speaker is me. I'm introducing myself. Because of the holiday, we had some issues getting a real nutritionist. So my disclosure is that I'm not a nutritionist, but I do love food. And food is important. We all love it. I have an Italian background. I always say I'm Italian, but then until I meet my Italian colleagues that actually live in Italy, then so I'm Italian American, and a lot of cultures really, form on food, and so it's important to know what foods are good, what you need to do, because there's all these theories out there which we've already addressed. I'm going to review the common cancer food myths, tips on eating while on treatment, and then tips on eating after treatment. Okay, so the eating while on treatment is very different than eating after treatment. It's important to distinguish the two. Okay, so debunking the cancer food myths, we already talked about this myth, but let's just reiterate it one more time for everybody. Okay, so the idea, what Dr. Benjamin and Mackey and all the experts were saying, is that, yes, if you grow cancer cells in a petri dish and you feed it sugar, it will grow, okay? It's the idea behind the PET scan. We try to, cancer cells as well as other cells use nutrients to grow and divide. So you get a PET scan, you get radio-labeled glucose, which is sugar, and you can see where there's activity. The problem is that with the theory is that your good cells need sugar, okay? And the body doesn't know the difference. So if you try to deplete your body of sugar, then what's going to happen? The cancer cell is going to steal sugar from your good cells to grow. It will grow regardless. So you can try to starve your body of sugar, it's going to steal it. And if you really try to deplete your body of sugar, then your liver will try to make sugar on its own, and the sugar that liver makes is acidic, and it's called ketones. That's what the whole ketone diet is, and that is a catabolite, which means that breaks down muscles and energy, and so you're stealing. So if you try to starve your cancer, you'll really just starve yourself, okay? So you really want to be giving your body energy, which in the form of sugar, carbohydrates, proteins, fats, so that your body can fight the cancer, okay? And so that's where that theory comes in. So it's fine to eat your sugar, okay? Now, obviously, anything in excess is not good, and if you're diabetic, you know, you do have to cut down on your sugars, okay? But if you're not diabetic, and then, you know, you can do whatever you want. Yeah. So cancer cells cannot survive in the alkaline environment, okay? Cancer cells, again, they can grow in acidic environment, they can grow in alkaline environment, they can go in a neutral environment. So the whole theory, and I think that Dr. Mackey explained that very well. So there are a lot of people out there that are trying to make money off of people that have fear about cancer, okay? It's very scary to have cancer. It's scary when you have it, you have a fear that it's gonna come back. And people are harboring on that, and they're harboring those fears, and you're spending lots of money on trying to do that. And the best thing to do is, yes, you need to stay well hydrated. So water is important, and you do need to drink lots of water. So the amount of water that you need to drink, and sorry, I didn't put that on the formula here, but basically, however, what your body weight is, you divide that in 2, and that's how many ounces of water that you need to drink a day. So for example, if you are 160 pounds, you divide that into 2, that's 80 ounces, so that's about 3, those are about, 80 ounces of those 20 liter bottle of ounce, 20 ounce bottles, you need 4 of those a day. Okay, so that's the general rule. And so you don't have to have alkaline water, just regular water, okay? Herbal supplements fight cancer. There's a lot of myths out there. People are taking all kinds of herbal supplements, and we don't know what those do. So we talked about clinical trials before, and the importance of clinical trials to really show exactly the benefit of these medications. Just like the Allertumab, we thought it worked. It may work in some, but it doesn't work in everybody. And there was actually studies, they thought that, say for example, selenium, a nutrient that people thought that it could fight prostate cancer, and actually they finally did do a study, and actually people did worse on that. So you get most of your fruit, you get most of your vitamins from food, okay? Food contains the majority of your vitamins, and that's all you need. Now, with the exception of calcium, the normal American diet does not provide enough calcium for post-menopausal women, and also patients that are undergoing chemotherapy. That could deplete your body of some calcium, so you have to talk to your doctor. Some people do need to take calcium supplements, but the majority of times you can get all your nutrients from eating your 4 food groups. Okay, artificial sweeteners can cause cancer. That can be a myth. That's in super high doses. Obviously, you don't want to be having a lot of chemicals. Okay, so processed foods, yes, we don't have all the good data on that, but you can, everything in moderation. Okay, so what are the common nutritional challenges during treatment? So I'm going to talk about these 4 challenges: tips for nausea and vomiting, decreased appetite, coping with altered taste, coping with diarrhea, and coping with constipation. So tips for nausea and vomiting, key is you have to most of us are used to 3 meals a day, okay? And it's hard to get those 3 meals a day in because these meals are large, and if your stomach is gotten smaller or it's being pressed on by tumor, it's hard to get those 3 meals a day. So you really want to have small meals throughout the day. Now, if you are just a meat and potatoes kind of person and you just have to have your breakfast, lunch, and dinner, well, then what you could do is you just take your breakfast, divide it in 2, and have half your breakfast earlier, and then come back an hour later and have half your breakfast. Lunch, you can have a full sandwich. Make your full sandwich. You have half the sandwich and then you come back an hour later and have your full sandwich, and you can do that, okay? So, and then clear liquids, you have to maintain hydration. That's key because part of nausea and vomiting, it could be caused by dehydration, okay? And so then you get into this vicious cycle. So if you're not drinking enough fluids, you're gonna be more nauseated. So you really wanna be watching how much you're drinking, and you wanna get most of your liquids in before 4 o'clock, because then you're up all night going to the bathroom. And how can you really tell if you're hydrated or you're not hydrated? Look at your urine, okay? It's very easy. You look at your urine. Who looks at their urine every day? Good. You must have. Anyway. So look at your urine. What color is it? If it's light yellow or clear, then you know you're being well hydrated. You really want to be clear, but even if light yellow. If it's dark yellow, or there's some red in there, then that's when you're really dehydrated, and you need to drink more fluids. Sometimes you're just too nauseated to get those fluids in, and that's when you need to talk to your doctor and you say, listen, my urine's dark, I've been trying to get more fluids in, I can't do it, and then it can set you up with IV fluids, and then IV fluids will hydrate you, and that could break the cycle, okay? And then you can freshen your mouth by rinsing it with some baking soda. That can help a little bit. Add some baking soda, some salt, swish and spit. That kind of clears up the palate a little bit. And if you're, try to eat some bland foods, not fatty and greasy. So that's when you're having the nausea. Also, you need to take your nausea medicines too. And some people need to keep what I call a food diary, because everybody's different. Some people can eat whatever they want. Some people have different types of foods that just don't sit well with their stomach. And some people never had stomach problems, and now they're on treatment, and now they're having these issues. And the best way to figure it out is by keeping a food diary, writing down what you're eating, and then you can determine, okay, wait a second, I was nauseated after this, and then you can get a pattern. Now you want to see a pattern, because can't just say, okay, I was nauseated because I had this broccoli, the one day. You kind of really have to see the pattern. If after several days of eating the same thing, you're feeling, then you just say, you know what, I'm gonna avoid that food. Okay, dry foods like crackers, toast, that helps as well. And you also have to be reading your meds, because some of the medicines that we put you on, antibiotics and such, you have to be on a full stomach or an empty stomach, so you really have to kind of keep note, because some of your medicines, just having them on an empty stomach can cause that. Now, a lot of things cause a decreased appetite. The cancer can cause decreased appetite, and the medicine. So what can we do to help that? Again, the small meals throughout the day, eat by the clocks. So we're so used to eating when we're hungry, okay? You eat when you're hungry, and you eat what tastes good, right? But now you have to think of food as medicine, right? Sometimes you don't like the taste of when you don't really like the taste of your medicine, but you take it anyways. And you don't drink your medicine pills when you're thirsty, you just have to take them in a timely manner. So if you're noticing you're not eating and drinking enough, you really have to just say, okay, I'm gonna eat when I'm not hungry, and I'm gonna say at 10 o'clock I'm gonna have this, at 12 o'clock I'm gonna have this. And just like how you have to take your pills at 10 and 12 and whatever time, you have to use food as treat it like medicine. Okay, and make sure you kind of keep your pantry well stocked with foods that are quick. Okay, you don't have to be Julia Childs and make these elaborate meals. Just have something that's going to be easy that you're going to get to, and have your bedtime snack just to get some extra calories, and then try to get some heavy protein foods, which I'll have a list of that, and then and you want to drink your liquids, and then but try when it's time to eat, try not to drink while you're eating, because then you get too filled up with food, with the liquid, and then you can't get the food down. Okay, and then so again, you want to have your liquids the other times, and then don't have liquids with your meal unless it's a dry meal. Okay, altered taste. You can And different medicines cause different taste bud changes, okay? Different chemos have different taste bud changes. Cisplatin, you can get more of a metal taste in your mouth. Other things you can, other chemos, you can get mouth sores, you can have different taste buds. And even the newer targeted therapies, the oral meds, you think you're not on chemo, but it does change your taste buds. So you want to choose foods with tart flavors, lemon wedges, lemon vinegar, pickled foods. You can marinate your foods in balsamic vinegar. You can add lemon juice, as Susan was saying, to water. And then you may need to kind of season up your foods. And then you can have fruits, and then you can kind of rinse your mouth off with this concoction that can help. And if you do get that metallic taste from the chemotherapy, then you can try to avoid the metallic forks and knives. You can use plastic forks and knives, and so that you don't taste that metallic taste, and avoid canned foods. And then, if you have diarrhea, okay, a lot of the medicines can cause diarrhea. So then, again, you can try to avoid, high fat foods, spicy foods. But again, everybody is different, so you have to keep that food diary. Maybe something is just really just not agreeing with your stomach, and so you want to be writing these things down. And then, again, when you have diarrhea, you can deplete your body of nutrients such as potassium, so you want to make sure you're replacing that with electrolytes like sit-on broth or Gatorade. And then you can add things to bananas can help bind you. Rice are some of those things, and hot caffeinated beverages, you want to try to avoid those. And then constipation, pretty much everything's the opposite. And so, and diarrhea, everybody has a different kind of thing. We want to try to avoid, it's fine to have soft stools, but diarrhea, if it's loose, liquid, and you're having more than 2 to 3 bowel movements a day, then you can really get into some trouble. So you want to be making sure you're talking to your doctor about that. And there are medicines to stop the diarrhea as well. Okay, constipation. Everyone has their definition of constipation, right? So, when I was in med school, I learned that actually, when I was surprised, constipation, that a normal bowel movement could be, a couple times a day to only once every 1 to 2 weeks. Okay, so that's actually normal, which, yes, you can feel uncomfortable, and especially if you have large pelvic tumors, you want to be moving the bowels, but you may just not have a bowel movement every day based on your medicines that you're taking, and you can't think that, oh my gosh, there's something wrong with me. I used to have bowel movements every day, and now I'm not, if you're on medication, and you may just have to learn to live with that, but there's certain things that you can do. Try to eat similar time frames, and so that you also have to allow yourself to have enough time to go to the bathroom. You have to drink your water, okay? If you're dehydrated or your urine is dark, you're not going to have a good bowel movement, okay? Until you're well hydrated, that's when you can get the bowel movements. And then, prune juices, vegetables. Personally, I have spinach every day, okay? I put it in my shake. If I don't have my spinach, not going to the bathroom, okay? So spinach is very good. Other things, liquids at room temperature can help, okay? And eat foods that are high in fiber, okay? So everything we did for diarrhea, we do the opposite for constipation. Loss of appetite, okay? There's a lot of different things that cause loss of appetite, changes them in the metabolism, the food breaks down, so cancers speeds up your metabolism, and we should actually try to figure out what that is, and then we can bottle it and then put it to figure out what the chemical is that speeds up your metabolism and causes you to have low appetite. Then we can create a pill for that and then sell it to the rest of the Americans, and then with the money we can have more cancer research with that. But anyway, so other causes, not only that, if you have a tumor in your abdomen, it can cause swelling, and that could decrease the appetite. If you have ascites, which is fluid in your abdomen, that could decrease the appetite. And of course, the medications, and if you've had radiation to certain areas in the abdomen. So again, other side effects that can cause appetite loss, the nausea, vomiting, mouth sores, infections, difficulty swallowing, pain, fatigue, and depression. Actually, a lot of times it's hard to really tell the difference between if someone does really have a low appetite because of the cancer from the chemo, or are they depressed, because we know that can cause it too. So we want to make sure we are addressing all these issues. So how do we help with managing it? We first want to try to figure out what's causing the underlying cause. Is it from nausea and vomiting? Well, then we have to make sure that we get that under control. Is it constipation? If you have low appetite because your body's all filled up with stool, well then, we can take measures to relieve that. So again, we have to figure out, can we figure out the cause? Now, once you have a low appetite, then essentially your stomach is like a muscle. It is a muscle, right? And and you get hungry when the stomach is full, and so if you don't feed your stomach, then the stomach will get smaller, and then you won't get the sensation of fullness, and then you're not going to be hungry. Okay, and so we have to try to slowly expand the stomach to get you to be hungry. Okay, and again, we want to be trying to really, you don't want to be trying to. This is just kind of a long list, but basically, you need to try to make sure that you're getting your nutrients, and you're getting, because remember, your food is your units of calories or units of energy. So again, light exercise can help with appetite loss. And then you really want to we notice if you have a little bit of weight loss, that's okay, but if you have a lot, then we do send you to the dietitian, and you can have special counseling with the dietitian, okay? Sometimes, despite all the measures that we do with food and counseling on food, we can prescribe medicines to improve the appetite. Megace or megestrol or Marinol can improve appetite as well. But we try to really counsel the patient on just eating more smartly throughout meals throughout the day. Okay, so that's while you're on treatment. Now, what about after treatment? Now, sometimes people on treatment actually gain weight. They don't get low appetite. They might have been on steroids, because the steroids can increase the appetite. They might have been on steroids to help with pain. They might have received steroids as part of their chemotherapy regimen to prevent nausea. And so then they wind up gaining weight. And so what are some of the things that we can do after you're done with treatment to try to help with that? Okay, so you want to eat well. So eating well, basically, if you have to have your fruits and vegetables. That's key, okay? Because it can help, scavenge cancer cells. Again, you can't just get all your nutrients. You can, if you want to become, there are these vegan movements where you just do the plant-based. Right now, there's no data to support that being on a vegan diet can prevent your cancer from coming back. If you speak to vegans, they say they feel better. Okay, my nurse practitioner is a vegan. She says she feels better being a vegan. Okay, but it's possible that when people take these extreme diets, is that, well, what are you doing when you're being a vegan? Well, you're eating your fruits and vegetables, okay? And a lot of people didn't eat their fruits and vegetables, and so now they're eating all these fruits and vegetables, and they feel better, okay? And they're not having all their junk food, and they're being selective with their foods, so of course they're gonna feel better, but there is no data to support that it can prevent the cancer from growing, but it is good to learn about your fruits and vegetables, and you really do need to incorporate your fruits and vegetables into your diet. Okay, so we want to try to avoid fast food and processed foods, And so what I say is you shop at the periphery of the grocery store, okay? What's on the outside of the grocery store? You got your eggs, you got your dairy, okay? You got your fruits and your vegetables and your meats and your chicken and your fish. What's in the middle of the grocery store? All your processed stuff that's in boxes and bags. Now, we can't be, we're human, so we can't say we're never gonna have this stuff. We just wanna try to limit how much we have, okay? And so you don't wanna be, we can't ever have this. Just everything in moderation, okay? So again, so not one single food has all the nutrients, but we can kind of eat by color, right? And so we have our various colors, and so just say, let me just have some colorful things on my plate, and usually the colorful things, and that does not mean Fruit Loops, okay? That's a different part. Although if you want to have Fruit Loops every once in a while, fine, you only live once. But let's just, let's try to have it. It'd probably be better to have the yogurt and use the color of the Fruit Loops and the artificial flavor to actually, they've got the lemon, the green, and, use those actual fruits and vegetables. And then, you can do like the plate method, okay, where you have your meat on one, or your protein, and then you have your grains, and then you have your vegetables, and you want to have half vegetables, half protein, half grains. Or you can do, and you want to have at least 4 fruits and vegetables a day, and you don't want to be cooking them to the point where they lose their color, okay? So you want to make sure they lose all the nutrients. So try to, bake them. If you want to fry something every once in a while, that's the only way you're going to get your vegetables to get it fun. Sometimes that's how I bribe my husband to eat his vegetables. But anyway, I like to, kind of saute these things. Olive oil is really good. Obviously, a little garlic and olive oil, a little salt and pepper. That's really all you need on a lot of things. And you'll be surprised. A lot of people say they never ate their fruits and vegetables, and then if you cook it properly, you can really get some of these vegetables. It tastes very good. Fruits, you want to be eating about 2 to 3 servings of fruits every day. You want to try to avoid the canned ones. You want the fresh ones. And then your grains. You want to still be getting your grains. Everyone's like, oh, no carbs, all this stuff. You still need your carbs. Carbs are units of energy, so you still need to get those vegetables in. And then lean protein, fish, chicken, veggie burgers, eggs. I think it's okay to have some steak every once in a while. Do you want to have steak every day? Do you want to have a hamburger every day? No. But, once a week, once a month, that's certainly fine. And remember, you're trying to, we want you to live longer, and we want you also to be enjoying your life too. Again, dairy, if you got to kind of listen to your body. Some people just can't handle the dairy, and there's dairy supplements, but you really need to dairy gets a bad rap, and a lot of people say, oh, I don't do well with dairy, but really you should keep a food diary and actually see, are you really lactose intolerant, or you were kind of just running that. So there's certain things like milk. Personally, I can't really have milk well, but somehow I could eat Greek yogurt and cheese. So you really want to make sure that you don't have a blanket statement that you don't tolerate. And you do want to, the dairy is a great source of calcium, and you do need to make sure you're getting your calcium in. And then you have your healthy fats as well, peanut butters, pumpkin seeds, those kind of things. And another way that's a much easier way than all this is counting your calories, okay? Counting your calories is pretty easy. It's actually, I used to do it all the time before the internet, and then I have to have a book and look it up, and now it's like so easy, you don't even need an app. You could just like Google how much is a banana, okay? And you can easily figure out the calories. And the calories, basically calories are units of energy, okay? And units of energy, that's what we need. So when people going to ask someone whether they're fatigued or not, well, how much are you eating? If they're not eating a lot and they're losing weight, then they're losing out on calories, energy, okay? And so how do you figure out how many calories a day you need? Well, it's based on kilograms, but since we're in the US, we use pounds, okay? So there's a formula that you can use that's based on because it's 2.2 kilograms per pound. But anyway, so you take your weight and you add 0 to it, and then that's how many, and then you add your weight, and that's how many calories per day. So, example, if you're 180 pounds and you want to stay 180 pounds, then it's you add 80, you add a 0, and then plus 80, and that's 1,880. You can round up if you want to lose weight, round up if you want to gain weight, round down if you want to lose weight. But anyways, 1,900. So if you just sat and did nothing all day long and you had 1,900 calories, you would maintain your weight of 180. Okay. Now for every 10 minutes, what I forgot to put down that, every 10 minutes of rigorous exercise, you lose about 100 calories. Okay. If it's light exercise, maybe about 50 calories. So you have to add that in. Okay. Now if you're undergoing cancer treatment and you have cancer, you have to add about 10% of that. Okay. Anywhere from 10 to 20%. So if you're undergoing cancer treatment, chemotherapy, and you want to maintain your weight of 180, then you have to go up to about 2,100 calories, okay? If you are not undergoing cancer treatment and you feel like I'm at 180, but I was 160, how do I get back down to 160? Well, to get back down to 160 is that every 3,500 calories is 1 pound. So if you want to lose 1 pound a week, then you add 500 calories. If you subtract 500 calories a day from your diet. Essentially, if you want to weigh 160 pounds and you add 0 to it, that's 1,600 plus 160. Then you have to eat about 1,700 calories a day, and eventually, over time, you will have that. Now, exercise, and that's our physical therapist will be here next to talk about that, that helps it, okay? Because it is hard to, if you're trying to lose weight, to try to restrict it. And so you can, you know, you can add and subtract based on exercise, okay? So if you want to gain a pound a week, you add 500 calories. So ensure those kind of things count, you know, have an extra thing of peanut butter, have an extra thing of ice cream. If you want to lose it, try to avoid those things. And it's really simple. And you don't want to do any kind of fad diets, okay? Healthy way to gain weight is about a pound a week. Healthy way to lose weight is about a pound a week. Okay? And again, you can go to American Cancer Society. There's American Cancer Institute of Clinical Research, Cancer Research. And I also got some information from the NCCN guidelines, the patient group. So if anyone has any questions. No questions. All right, good. Okay.
Thank you, Dr. D'Amato, or should I say Dr. Dietitian?
Okay, break is over. Fantastic. Okay. This next speaker is our last speaker. The last means usually the best. Okay, so we saved our best for last. Talked a lot about exercise and rehab. And so Annemay, it has received her doctorate in physical therapy and bachelor science from FIU, and she's a certified lymphedema therapist at University of Miami Health System in the Department of Physical Therapy. So we have most important thing to talk about, rehab and exercise in the sarcoma patients. So really thrilled to be working with Annemay and the rest of the physical therapy team and occupational therapy team. So please give her a warm welcome.
Good afternoon, everybody. My name is Annemay, Lelis, and again, I work in the Department of Physical Therapy at the University of Miami. Yeah? There you go. Okay. So my goal today is just basically, like, what now? So after the diagnosis, after the whole treatment plan, and you hear all these things about you should exercise. Exercise is good. No, this is what you're supposed to do, but nobody ever tells you how is it supposed to be? Like what should you do? So my goal is to help you recognize when rehab is needed, signs and symptoms when you need help, introduce what oncology rehab is, and give you tips and guidelines and guide you on how to increase your physical activity safely. So again, like I was saying, after your whole treatment process, right? Everybody tells you what to do, you should exercise, but there's many questions. Am I supposed to be able to get back to normal? Am I supposed to get back to work? How am I supposed to get back to work? What am I allowed to do? Am I going to hurt myself more? Is exercise okay? So these are all valid questions that is normal to ask. So this is where rehab comes in, because our goal is to improve or maintain your quality of life, your independence, integrate you back to the social life and into the community, all right? Increase your function, and basically it will also help your psychosocial being, because you are being able to go about in daily lives. And we will guide you throughout this whole process. So in rehab, we have 3 parts: physical therapy, which I am. Think about movement, right? Being able to walk, balance issues, to prevent falls, manage pain, the fatigue aspect of things, just basically strengthen and get you back going. Occupational therapy is there to improve as far as getting you back to your activities of daily living. If you're a parent, to get you back to taking care of your loved ones, to get back to work and your leisure activities. They also help with cognitive deficits, like mental fog, fatigue, and just like loss of concentration. Speech is here if you have any difficulty in swallowing, difficulty with talking, and they also work with memory problems. Okay. So why do we need rehab? Why do we need exercise? Well, as you've all been here for 2 days, and with all this abundance of info, but basically that's why. The effects of cancer itself has side effects to the body, the medicine that you guys are taking, the radiation therapy that you have received, and also the surgery itself. They all compounded into some deficits that happens in the body, right? So going through it really quickly, chemotherapy, one of them is the numbness and tingling that you all feel in the hands. So it's not only the hands, but imagine the feet. So when you think about it in the feet as well, it can also affect your balance, right? Balance can increase in falls. So safety is an aspect. Another one is vestibular issues. If you feel like you're just like in a moving car all the time. Cognitive dysfunction is basically just difficulty managing tasks. Forgetful. Another one is cancer-related fatigue, which I'm sure you've all known about it. It needs its own slide because it's like the number one or the most frequent complaints from survivors. And it's different than any other just feeling tired, you sleep, you wake up and you're good. No, it's like you feel tired and you feel you're okay, but then when you're tired the whole day. It's unrelated to, proportionate to your task, right? So it's like you're taking a shower and then you're like, man, I'm so beat up, I gotta take a nap. And then the nap is not just 30-minute nap, this is like a whole day. So these are signs and symptoms that you might feel. Just being too tired to eat, irritable, everything just feels heavy, just bogged down. So these are signs and symptoms. So radiation therapy. So think about it like you get a nasty sunburn in your skin, but that's just only in the skin. So imagine what happens inside, deep down. It will affect your bones, it will also affect your ligaments, your tendons, your muscles. So what happens is they tend to start kind of like tighten up. They tighten up and then they contract. They lose their ability to move, right? So when you think about it in your joints, it decreases your ability to start moving. Decreased joint mobility, and then sometimes it can cause pain. And then the scar tissue that happens after that, either because things start to harden, right? So things to consider is, which I will show you how little flexibility exercises, but like daily stretching will help, even while going through radiation therapy. Just little movement, if it's around your pelvic area, just stretch your thighs out, just to kind of open things up so it will not go like this. When we're in pain, and if we don't like to move, we tend to just bog down, we sit like this, because we're, that's just normal, but we have to open up. We have to open, we have to stretch, all right? And then side effects of surgery. So now this one, again, it depends on the part of your body, right, that's being affected. So if it's your legs, we're gonna teach you how to get back to walking safely, upper extremity, just also help with pain. Big one is just help with pain. Again, things to consider, just ask about special equipment that will help you around your home. So that's real quick. The next one is lymphedema. Okay, so after surgery and probably compounded with radiation therapy, sometimes the water, we have water moving around all the time. But there are times when it's just in the limbs, it just doesn't get up, it doesn't have enough help to get back and get recycled through our bodies, right? So think of it like as a traffic jam. So what happens is your limb just starts to get kind of bigger and swollen. You will feel a little bit heaviness in the area, it just feels tired, it just feels tighter sometimes. Those are signs and symptoms that maybe, if it's in the earlier stage, that maybe you just need to take a break. Just relax, let your body reabsorb things, and then go about your daily activities the next day. So that's that one. But if you do see signs and symptoms of your limbs starts getting bigger and swollen, please contact your physician, and then so send you to therapy, and we can help you with that. And then that's that one. So what can you do to overcome these side effects related to sarcoma? First, you have to ask yourself these questions, like, are you always tired? All right? Are you falling? Are you unstable? Do you have numbness and tingling or pain, burning pain in your hands and fingers? Your limb is getting swollen. These are all valid questions. And then that compound, another way for you to, if you say yes to these, then it's okay to ask for help. And then help is rehab. Another way for you to see if you need about your functional activity is you guys all can try this. We do this all the time. It's called the 5 times sit to stand. All you need is a chair. All you do is cross your arms. You guys can try it out if you want. And all you do, without using your arms, is you're going to sit and stand 5 times. That's all you need to do. And after you're done with that task, you ask yourself, how do you feel? Were you tired doing this? Do you need to use your arms? Was it less than 12 seconds? If you answer, if it takes you longer than 12 seconds, and then if you're very, very bogged down, plus all this, then again, seek help. Rehab is here as your lifeline to help you integrate back and help you get your function. Just contact your physician and your medical team if you have any problems with that, because they're there to deal with your disease process. And if you don't say anything, then they won't know. And then you have to be a voice. You say, these are not normal, what you're feeling, and it's okay to get help, all right? So that's one way for you to cope. Another way for you to cope, a strategy, is energy conservation. So the 3 Ps, prioritize, right? Pace yourself and position. You don't have to be Superwoman and Superman and do everything all in the same day. You create a plan. You do the most important things first, take a break, and then do them again later. You can continue doing this throughout the week, right? Set up a planner of things that you would like to do. Again, pace yourself. You don't have to, it's not a rush, slow and steady wins the race. Just chug along, keep on going. You gotta take your breaks, right? Some people forget that breaks are as important as moving. So always take your break. Position. Instead of standing up, sometimes you sit down. Sit down while ironing, sit down while brushing your teeth, whatever it takes. These are all strategies for energy conservation, and it's really helpful, especially if you have cancer-related fatigue, because that fatigue it can last up to all day, so you still need to move, right? You still need to do your things at home. So these are ways for you to cope and how to manage your daily activities. Another one that you can do is exercise. Why exercise? Oh. But yes, it's okay to exercise. Why? It's even recommended to exercise. It's because exercise, if you do it consistently, it will start producing really feel-good hormones inside your bodies, all right? And then you just keep on doing it. Keep on doing it, you will reap the benefits. It will help in decreasing fatigue, lose the weight, or maintain your weight, just physical function, and then just basically improve your overall health. And it can even manage long-term and late effects of the treatments you're getting from the cancer, right? Now, so these are like, go exercise. Well, how are you supposed to exercise? What are the recommendations, right? So you can't just go out there and then not know what to do. So in the pamphlet that I gave you, it has all this information. In the back, it also has the recommendations, right? So this is very important to know. Like while you're receiving chemo, it's a little bit different than after, all right? During chemo, so for me, I don't recommend exercising the day of or the day after, because during chemo, you will dip down, right? Your blood count, your blood levels will go down, so you are gonna be very, very tired at that time. And then that's the point, chemo drops you down, right? So take a break, rest. You don't need to go out there and start walking. Listen to your body. And then after those first 2 days, your body will start to rev up again. So let it rev up. So probably about 4 to 5 days, then you can start moving again, all right? So let's say light to moderate exercise. Not too crazy, but just something that what your body is able to do every other day. And then in between those days, do a little bit of light resistance exercises, which I'll show you later. Just very light. But then when it's time for your next cycle of chemo, again, when you take it, take a rest, take a break, and then you rev up. So when patients come to me who are undergoing chemo, I tell them, hey, during your week, just don't come to therapy. Come after, come a week later, This is like a long haul process. Now, after chemo, this is the recommendation, 150 minutes a week of moderate intensity. Like, man, 150. That's like 30 minutes five times a week, all right? It's not that bad. And then you can break it up during the day. You can even do 25 minutes 6 times a day. Whatever floats your boat, as long as you get that 150 a week. Or 75 minutes a week of vigorous intensity. And also in the pamphlet in the back, I will show you how to gauge these things, because it's hard to know what moderate and light is. Okay, so that's aerobic exercises. Resistance is any strength training for your muscles, right? At least 2 times a week of moderate intensity, and flexibility exercises or stretches of major muscle groups. Basically, doing nothing and just sleeping all day is not beneficial. If you go all the way up here, working every day until you're all depleted is not good as well. You have to stay in the middle. You have to stay balanced. And then gauge, your body, gauge it, okay? So this is what I like to use. This is the perceived exertion scale. So all of these moderate intensity, vigorous intensity, you're like, what is that? This is it. So very light. So back there, what you can tell you, this is how you feel. You can breathe, you can air, you can take, you can do this all day. That's very light activity. You can do this all day. And then you move up to the green. That's moderate. You still can talk while you're exercising, but it's a little bit challenging, a little bit of sweat. like me right now. Just a little bit of sweat. All right, so that's this one. Somewhat comfortable, but it's a little hard. Now, vigorous activity is, you can only speak a sentence, all right, borderline uncomfortable. This is like you're really working. So when you go back here with the recommendations, with what moderate and light and vigorous, well, what they mean is, this is how you gauge it. Because my goal is for you to exercise, but be prepared and be safe on how to exercise. And this is how you gauge it. And everyone's moderate is different than mine, it's different than yours, your moderate is different than his. So this is the questions that you ask yourself, all right, when it comes to exercising. How do you feel? How hard is your body working? That's this one. Types of aerobic exercises, whatever it is that is fun, that will get your body moving. I live in Miami, they all love to dance salsa, so I tell them to go dancing. That's like their thing. And like, music is my life, then go dance. You know? And you know, when I tell them, like, go walking, like, it's so hot outside, then don't walk, do something else. As long as you get your body moving and you get your heart rate up, moderate or like whatever it is, that's what it is. Just make it fun. Make it whatever that you would like to do. Okay, that's aerobic exercise. So now, resistance. So we have those bands, right? So what you can also do is you can even tie it, make a loop, okay? I don't have one.
No, mine feels so good.
Thank you. Okay, so here, make a loop. Right, so we can do those. Well, I have heels, but yeah, that's not good.
We want to see you dance salsa now.
All right, these bands, they're great, man, they're great. Sometimes you see them advertised as like booty bands, but this works well. So this one, all you have to do is be safe. Everyone, please be safe. Just grab onto a chair or anything. Move your legs to the side. Easy enough, right? You can walk side to side, right? All right, walk forward, walk back. You can even do that first one, bridges, with this for more resistance, okay? Sitting and standing or squats, whatever that your body is able to do, do it. And use these bands, they're right there for you. 3 sets of 10 is usually how it is, but if 3 sets of 10 is too much, then do 3 sets of 8, 5 sets of 6, whatever it is. We just gotta get you moving, okay? So that's that one for your lower body. So now we have upper body stuff, okay? On the table, we can do planks, but hold on, okay? All right, that's another one. You can use the bands to use for your upper body as well. Like this, you can do rows. Okay, easy, you can open and close, easy, move it up there, there, all right? If you want a copy of these, I don't know, I think we provided for everyone, right? Yeah, okay, cool, okay. So that's this, 3 sets of 10, again, or 3 sets of 8, 5 sets of 6, whatever you'd like. But make sure to rest. People always tend to forget to rest, like dram into the next one. I did the whole 30. Like, man, you gotta give your muscles a break. You know, breaks are very important. Balance, ooh, this is great. We all forget about balance. So, tandem stand, 1 foot in front of the other. First, hold on, let go, you know, challenge yourself. 1 leg, all right? If you want a little bit more challenging, 1 leg, and then lift 1 arm up. Okay, those are balance exercises. Flexibility, again, really great if you're undergoing radiation therapy. Hold it for like 30 seconds and then let go 4 to 5 times. You just gotta open things up, all right? Especially in seated, all right? Bring your arm up and then just rotate your torso. They're really good because a lot of us tend to be stiff up here, all right? Because we sit like this all day. So open up, all right? Just rotate your body side to side just to open up your upper back. Stretching. Now, how to exercise safely. Very, very, very important. Again, contact your physician or your medical team if you're going to start a new routine, because you never know what kind of medications you're taking, and they know more about your situation. Just to say, hey, is it okay for me to start an exercise routine? Do not exercise, again, if your blood count levels are extremely, extremely low. If you have a fever of more than 100 degrees, these are all in your pamphlet. And if you have some really, really, really severe vomiting, diarrhea, nausea, because again, exercise is going to rev up your body. And if you have diarrhea or nausea or vomiting that's not going away, then you're already dehydrated, right? So just relax. So, and if you're already exercising, if you're starting to get vision changes, you're dizzy, just doesn't feel right, chest pains, dude, that's like stop. Your body's not able to handle it. Something's going on. Just take a break. If it's not going away, then you gotta call for help, right? So these are tips on how to do it safely. And so for me, you got, it's been like a roller coaster, right? Ever since from diagnosis to the treatment plan. Everyone's telling you what to do. You gotta go here, you gotta do that. It's like a whole one after the other. So exercise is a way for you to take control of your body, all right? It's something that you can do for yourself, all right? And you gauge it, but it's something for you, okay? Something that you can do, like you take ownership of it. Out of this whole crazy chaos that's going through, this is something that you can control. And if you do need help, you have a team of specialists in the rehab department. We're always right there. Think about, that's why I like this picture. It's like a lifeline. You just ask for help, and we're right there. Thank you.
Thank you so much. Does anyone have any questions?
Now everyone's questioned out.
Everyone's
questioned out.
Yes.
What effects of water aerobics or water exercises?
That is great, actually. Just make sure that if you've had surgery,
If surgery is involved, just make sure that the surgical site is already healed and closed, okay? And usually when you're going into radiation therapy, like active, pool is not recommended, so it's usually active, okay?
The second part of the question is, what about the heat of the water? Is it colder water or a warmer water?
To be honest, it's whatever you like. Nothing too hot, nothing too cold. Just, if you want to be more relaxed, then a little bit on the warmer side, but not too much. But if you just, it's on you.
Thank you.
You're welcome. Yes.
I just want to add to that. I'm a master swimmer and I went through chemo, but I couldn't give up the sport because it made me feel so well and I felt like it was moving my toxins and I needed that support in my group. But what I did, I took these big Band-Aids I got from either Cedars-Sinai, and they're completely waterproof, and I would just cover up my port area. I mean, it was very thorough, so I was able to do my hour plus, and I was completely safe. So I know you're not recommending it, but it worked for me.
No, but as long as we just keep it dry, because we don't want any infections going on. So as long as you keep it dry, good for you.
It worked. They worked
Yeah.
like magic. They're just big plastic, waterproof patches, and it saved me mentally
Awesome.
and
See,
physically.
that's what I'm saying. Just
Yeah.
let go.
thank you.
Thank you. Thank you. Oh, you're talking.
So we've come to the end of the conference
conference together and our time together. So I'm just going to quickly go through some closing housekeeping items. Make sure to please fill out your exchange evaluations. We really take those seriously, and we go through them every year and try to improve the conference year to year. You can always contact me as well. My contact information's here. I also have business cards outside on the Sarcoma Alliance table. And then for the evaluations, once they're finished, just go ahead and add them to the box up here. And then we're really excited to announce that we will continue to have this as an annual part of our programming, and our next Sarcoma Exchange will be, yay, in Los Angeles. Dr. Charles Forsher will be our host next year. It'll be July 17th through the 19th. Just save the date for that weekend, 2020. And then you can watch for more information on sarcomaalliance.org. And then, of course, we have a number of exciting activities because we'll be based in Los Angeles next year. We will be partnering, hopefully again, with LAX to light up everything as yellow to create more awareness about sarcoma. And please make sure to check the website. We also have the Sunflower Days initiative that I mentioned earlier in the program, and help, plug in. We're always looking for volunteers to help brighten a sarcoma patient's day. You can watch for more information on our website as well. We already discussed the raffle prizes. The presentations, all of the presentations will be accessible on our website as well as the video. We have a live stream the entire time, so you can always go back if you need a refresher on some of the content, and of course return your evaluations. And I just wanted to say, Dr. D'Amato was amazing throughout this entire. Can we just give her a huge round of applause? She's an amazing human, a really amazing human. So she helped recruit so many of the speakers, and we are so happy to have her as our medical advisory board member, part of our board of directors. And she has this is her second time through this conference, and she's just been amazing in helping navigate that. Our board of directors, I also want to give a quick round of applause for them as well. They have dedicated a lot of volunteer hours to make this possible. Our speakers, our facilitators, the support groups, Charles and Joseph, who helped put this together as well. On the event consulting side, better and improved this year as well. So I just wanted, did I miss anybody?
You.
Nicolita.
You. Alyssa, yeah.
Nicolita for principal performance. It was amazing, very inspiring, and the exhibitors, everyone. So thank you so much for pulling everything together. Gina, did you want to say anything as we close up too?
Say something.
Yeah, thank you all so much.
So just wanted, again, just to reiterate about the evaluations, this is only our second annual. So, last year was our first annual. We had a great turnout, and we had great evaluations, but part of the evaluations, you have to, give the good and the bad. So we really want to improve things as time goes on. I want to thank the sponsors because this was a free event. All the food, everything, none of the physicians and the rest of the speakers were paid for this again. So they've taken time out of their very, 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 very busy schedules. Nicolita, she has a warm place in my heart. She not only has sung for us, and also she raises a lot of money for Sarcoma Alliance, and that's really special. And then, of course, all the patients and their family members for coming here, listening to this. Some of the topics were very tough. Some of that, hopefully, with all these topics, you feel better about having sarcoma or having had sarcoma and not worse. And we really hope that you took a lot out of this, and we really, we wouldn't have done this without you, and it wouldn't have been so successful. So hopefully you've formed some bonds and some lifelong friends, and that you feel that you're not alone, which is our main point for Sarcoma Alliance. And that was the whole reason why Susan Leiter developed this great organization, is so for sarcoma patients to not feel alone. So hopefully that's our main takeaway, and we really thank you so much, and looking forward to seeing you soon at the next event.
Alyssa, if we still have some shirts out there.
Oh, yeah.
Okay,
oh, yeah.